Good afternoon, everyone. Thank you, AIOS Scientific Committee, giving me this opportunity. So, I am speaking on management of cataract with pterygium. See, we all know pterygium commonly occur in older patients, is usually accompanied by the cataract. Its prevalence varies from 0.7% to 31% in different geographical region. And removal of pterygium can be performed either before or subsequently with cataract surgery. So, what are the challenges associated with the pterygium? So, we all know the pterygium causes the astigmatism. The most common pterygium is the nasal pterygium, which causes the flattening of the horizontal axis, which increases with the ruled astigmatism. And because of this astigmatism, IOL power calculation is not accurate, and because of the pterygium, significant higher order aberration also seen. So, what are the clinical consideration when we are dealing with the cataract with the pterygium? So, which type of cataract? There are different types of cataracts: mature cataract, advanced cataract, early cataract, and there are the different types of pterygium: large flashy pterygium involving pupillary area, not involving pupillary area, small flashy pterygium, and the atrophic ones. But the most important is the patient's expectation. Some patients are very keen for the premium IOS, and they want to very fine vision for the different distances as per the for distance, intermediate distance, and the near distance. So, these are the patients we have to, and the other patients are the very comfortable with the minute deviations. Now, in this diagram, we can see here not only the length of the pterygium causes the changes of the ocular corneal surface, but the width and the area of the pterygium also causes the corneal surface changes. The recent study published in the American Journal of Ophthalmology 2024, it concluded that pterygium with a horizontal length of 1.7 millimeter and area of 4.45 millimeter square, and those with a horizontal length of 2.25 millimeter and area of 6.95 millimeter created 0.5 diopter and 1 diopter errors in calculated IOL power respectively. So, there are two options: simultaneous and sequential. So, as a rule of thumb, any pterygium of 3 millimeter or greater should be excised before cataract surgery, and patient with irregular Myers on keratometry or irregular central curvature or high corneal astigmatism on topography are candidates for the primary excision of the pterygium. And patient with the small pterygium at the limbus with regular Myers on keratometry, regular central curvature on topography, and low or absent astigmatism can have cataract surgery before pterygium excision. So, there are the clinical scenario. One is the patient having mature cataract with the large flashy pterygium more than 3 millimeter. So, we can go for the simultaneous surgery. So, with the presence of the pterygium, cornea is flattened. So, there is a post-surgery significant myopic shift. We have to reduce the calculate IOL power by the 0.5 diopter to 1 diopter, and the temporal or a steep axis approach would be better. Scenario 2, the atrophic pterygium less than 2 millimeter and any type of cataract. So, we can go for the cataract surgery alone. If patient wants the pterygium surgery, we can do sequential. And the scenario 3, the patient has a large flashy pterygium and the immature cataract. This is pterygium causes the irregular astigmatism, and the other pterygium involving pupillary area. So, in these cases, we have to go for the sequential pterygium. First one is the pterygium surgery followed by cataract surgery after 3 months. So, what are the advantages of simultaneous surgery? Provide faster visual recovery, reduce hospitalization, cosmetic improvement, reduce loss of work days, subsequent reduced overall cost for the treatment. But the disadvantages are increased surgical time, increased post-op discomfort and pain, delayed epithelium healing, visual results may be suboptimal due to scar, and the refractive surprises may be seen. And the advantage of sequential surgery, it gives the better corneal stability and subsequent higher predictivity of IOL power calculation. Disadvantage, double surgery, double expense, double recovery time, and the double follow-ups. So, surgery preferred, we have to prefer clear corneal cataract incision such as the microcoaxial phacoemulsification, and SIC should be avoided. And For the scar conjunctiva post-large pterygium excision, place the phacotunnel in a quadrant opposite the pterygium, such a temporal approach in the nasal pterygium. If there is a corneal thinning or flattening of the horizontal axis, to be performed phacoemulsification through the superiorly. Then what's the ideal time for the sequential surgery? So in this graph, this study published in the 2021. So in the first graph, we can see here at the 6 month, only 40% patient have the corneal astigmatic stability, and the mean keratometric stability get more than 73% cases at the 6 month. So if we are planning to monofocal or non-toric intraocular lenses, so the ideal time we can go for the 3 months. But if we are plan for the premium IOS or the toric IOS, we have to wait for the 6 to 12 months. So IOL choice, it depends on the presence or absence of the corneal astigmatism. We have to do the keratometry and topography should be 6 weeks after pterygium excision, or preferably after repeated 2 weeks. And in patient without significant corneal astigmatism or demonstrate no higher order aberration, we can go for any intraocular lenses. But the multifocal IOLs and the toric IOLs are not a good options in an irregular astigmatism. So my take home message is that simultaneous pterygium and cataract surgery is necessary only in patients who can't easily access eye care facilities. In all other cases, we can go for the sequential surgery. But always keep in mind patient's expectation. Thank you.